Good morning. Me, Karthik Guja, Associate Director for the Endovascular Program at Mount Sinai. Welcome you to the monthly live case endovascular 5K webcast, live here from Mount Sinai, New York. Good morning, everyone. And here we have Dr. Krishnan, Dr. Kapoor, and their team who bring in a very interesting case today for you guys. Before we go on to the cath lab, a few announcements are the previous webcasts have been archived into the website for you to view in, and you guys can post in any questions you have, and we'll be more than happy to answer the questions. We have our Link Mount Sinai Symposium for the endovascular live cases, which is going to be very interesting this year, where we have live peripheral cases, aortic cases, and venous cases, which will be transmitted from 11th, 12th, and 13th of June. And our next live case webcast will be on, for the monthly webcast, will be on June 20th. And before any further delay, we're going to be going to the cath lab. PK, good morning. Vishal, good morning.
Good morning, good morning, good morning. Welcome everyone. We've got a really great case here, very tough case with the lady with obviously critical ischemia with non-healing ulcer of the foot. But before we get to the case, Vishal and I want to just echo what Dr. Guja has said to all of you, that Link Mount Sinai is around the corner. We've got a fantastic program with really world-renowned faculty there for you guys to come and participate. I do want to tell everyone who's out there that we have a global exchange forum that we posted on the website. We did this as a last-minute thing here to increase the interest and the participation of the audience into Link Mount Sinai. And what this is really a forum for all of you to be able to present your live cases. So it's occurring in the technical forum with different moderators during that time. And what it'll afford you is the opportunity to be able to present your cases in front of obviously the entire audience, as well as in front of world-renowned faculty. Talk about how you tackled a technically difficult case, and really talk about some of the other thoughts and learn from one another. Really fosters the environment of learning that we want to talk about. And I think it's a phenomenal way for us to be able to let everyone participate together in making this happen. So there are 10 slots. Currently, there's approximately 5 people who've already applied. What's available is it's a scholarship in the sense that we're able to provide a hotel for you for the entire symposium, including Dr. Sharma's end of the symposium. The hotel-wise, the airfare-wise, we're actually figuring out what the budget is to see whether we are able to get that. Show me above, guys. So I think that this is a phenomenal situation. Why is it blunted like this? Oh, you're drawing, okay. So I think this is a phenomenal opportunity for everybody to be able to participate. So anyway, after that, I just want to go over a couple of other things. We're going to be doing approximately, I think, eight cases a day live from Mount Sinai, and approximately another 8 cases a day in the peripheral arterial disease section from Germany. So all to total 16 peripheral arterial disease cases spanning the spectrum from simple, how can you say, sort of discussion-based cases to talk about approach, to complex technical cases where we're going to talk about what we do and how we all can succeed in these difficult cases. The second part is the aortic part will be ongoing, as will the venous part. So there'll also be aortic cases, albeit a lot less because of the duration of those cases, and the venous cases will also be there with Dr. McKinsey and Lickstein leading those two, along with Dr. Torsella. So I really welcome all of you. I think it's going to be the best Link Mount Sinai we've ever had, and we really look forward to seeing all of you there. So without further ado, Vishal needs no introduction. Dr. Singla next to us, he's our endovascular fellow. Dr. Lascano behind us, he's our resident MD nurse practitioner. And then behind is Elizabeth, our dedicated endovascular nurse, Marichu's in Cancun. And we'll get started. Go ahead.
Sure. Morning, everybody. So we have a really tough and an interesting case. This is a 71-year-old lady, has a type 2 diabetes, hypertension, CKD with a baseline creatinine of 1.6, known history of peripheral arterial disease, and about 3 years ago, she had a similar presentation with an ulcer on the first toe. We don't have full records, but family said that she was managed initially conservatively at outside hospital, and then over the course of 2 months, she ended up having a right below knee amputation. This time, she developed an ulcer on the left first toe medial aspect about 6 weeks ago, and associated with rest pain. They went to the same hospital which they went first time when she had a right below knee amputation, and apparently they were told that it's going to be a conservative management and see how things go. At home, she's on aspirin, metoprolol, Lipitor, insulin, and hydrochlorothiazide. Her vitals were pretty stable, and on exam, she had a monophasic DP signal with a no PT signal on the left side. Next slide. Her labs are pretty unremarkable, other than a hemoglobin of 10.8, which kind of matches with her known CKD, creatinine of 1.6, and she had an ABI of 0.53 on the left. Had a duplex done from the referring facility from where she was initially seen, and they mentioned a moderate disease in SFA and occlusion of AT and PT in mid-segment, and there was no note made of the peroneal. As I mentioned earlier, the patient was recommended again a conservative therapy, but since she had a below knee amputation first time, they came for a second opinion to us. We saw her in clinic, and we decided to do an angiogram about a day earlier, and we took some pictures. We're gonna review the images.
Do you have them? Or?
No.
Yeah. Okay.
Yeah.
So the pictures Dr. Kapoor is just going to go over. Just want to say the iliacs are normal.
Right. So we just do regular digital subtraction and angiography. You can see there's some moderate lumps and bump disease proximally in the SFA. There might be a so-called borderline significant disease in the mid-SFA region. We could probably talk about and fix it on our way out if we need to. We think it's appropriate. But mainly focusing on below the knees, where today the crux of the story is. You can see the amount of significant disease, almost like a 3-vessel below the knee occlusion. There is AT which goes down, but it occludes in the midsection. Peroneal is gone with significant TP trunk disease, and PT is gone. That's another one more shot of the below the knee segment you can appreciate right there. So pretty much pretty significant. There's distal reconstitution at the DP as well. So there's pretty significant disease all the way down, and that's probably what's causing being a part of the ulcer in her case at this time.
So you can see here, Karthik, that she's got an occluded perineal with reconstitution in the mid, like Vishal was saying. The interesting is the foot shot shows at the distal, you can see the dorsalis pedis coming back. So I think this is the kind of situation. She's got I guess angiosome-wise a dorsalis pedis ulcer, right?
Yes.
And so therefore, I think our goal here is to revascularize that. So I think you have prepared something on angiosomes, or
A few slides, because we already.
So let's do this. I'm just going to tell everybody what Vishal and I discussed and how we're going to approach this, and then I want him to talk about this, and maybe our crew can put on the fluoroscopy on the side if they can, and so everybody can watch. But I want to just talk a little bit about what we've started doing. So we've started doing this sort of support technique in these kind of long segment occlusions. So we've got our 45 centimeter sheath at this level, through which we send a Terumo Navicross, which is 125 down to this level. Through the Terumo Navicross, we send you can either use an 018 Trailblazer or an 014 fine cross. In this situation, Vishal and I said, let's try the fine cross. If we need to upgrade, we'll upgrade. You could do the alternative to save time by just going with the Trailblazer and then go to the fine cross if the Trailblazer doesn't cross. Either way, it's really no big deal. So I think at this stage, as far as the imaging, I think it's important also for everyone just to look at what we see here. So you see here that it's a lady who's obviously got the amputation on the other side. Very poor imaging from above. So one of the things that we've learned as well here is to get selective, at least at the level of the pop. But here, since we're interested in the anterior tibial, we've got the catheter in what I think is the anterior tibial, and Vishal is just going to put it on DSA for me. And we got it right here. And I think what we're going to do is just going to inject and see whether this is the dorsalis pedis, AT or not. What you might be surprised to find is that there's a lot of hibernating vessel, okay? So there it is. So there's not really much hibernating vessel. So this is going to be a really tough one. I'm going to take another picture here just to see whether we're in the right vessel, and we can discuss that. So you can see here, yep, there's the perineal backfilling and not much hibernating vessel. So our initial wire choice is going to be to go with a fielder. And then we're going to go with we're going to upscale it from there. Excuse me. What is this? A command rather than a fielder. And then we're going to go ahead and upgrade.
What do you think about the popliteal?
It's significant, Karthik. That's what Vishal and I spoke about. I think we got to fix a lot of stuff here. I think that, there's no question inflow is part of it, but her ulcer is quite significant, and I think we need to get straight line flow into that foot if we can, and then if not, then we can at least open the perineal, and if we open the perineal, it'll at least help her a little bit, maybe convert this amputation to a what is it called, a transmet rather than a BKA. So with that, while we work, I'm going to ask Sandeep to present what he talked about.
So, coming back, as Dr. Krishnan mentioned, we started with a right CFA access, just going over the initial strategy. We have a 6 French 45 centimeter crossover sheath. We use bivalve for all our cases, with especially below knee cases. And what we are attempting right now is an antegrade lesion crossing, with the plan is to escalate the wires as we go. If this fails, as mentioned, we may access the DP, where it reconstitutes distally. And then as a definitive therapy, we intend to use a PTA and drug-eluting stents only for flow-limiting dissection. So next slide. So, for today's talk, over the last about 10 months, we kind of did quite a few CLI cases, and we went over our definitive therapies for below-knee interventions. And we had a presentation about the technical aspects, where how to choose wires and catheters. This case, I kind of decided to give a few slides on how to choose a vessel to fix, especially when you have a below-knee disease and all 3 vessels have significant occlusions or stenosis. So angiosome-directed therapy is a concept which has been there for about now 10 to 12 years. Initially, it came from the plastic surgery literature. Back in 1987, Dr. Taylor described it. And then this was promulgated in the arena of CLI back in 2006 by Dr. Oettinger. What it essentially means is that all these 3 vessels, they supply specific zones, and there are watershed areas in between them. And the idea is, if the ulcer is in one of these areas, to open up a vessel which is draining, which is feeding that area. So essentially, as you see in this picture, starting from the rightmost in the depiction, there is an anterior tibial angiosome, which is drained by the anterior tibial, which is the anterior tibial artery feeds into that. Peroneal angiosome breaks into 2 on the lateral aspect and the lateral calcaneal aspect. And then the posterior tibial supplies 3 angiosomes. One is the medial plantar, lateral plantar, and the calcaneal branch. Next slide. So this was the initial landmark paper by Dr. Oettinger back in 2006, which kind of described the importance of angiosomes when making decisions for CLI revascularization. Next. So over the last 10 to 12 years, there has been a lot of papers, and if I have to kind of summarize in one, there are 2 meta-analyses published recently. This is 2014, and there is one in 2016. What they essentially say is that if technically feasible and within the limits of doability, it is probably better to establish a direct inline flow. What it means is, if the ulcer is in the area of that angiosome, which it's better to fix the feeding vessel into that. Next slide. That's another meta-analysis where they looked only at diabetic patients, and they also kind of had the same conclusion, that it's better to have an inline flow with angiosome-directed therapy, especially for diabetic patients. Next slide. So beyond angiosome, another concept which I kind of find interesting is that what is the importance of the pedal plantar arch or the deep plantar arch. So there is one study which analyzed, or which looked at the successful below-knee interventions, and then they classified the plantar arch into 3 categories. And next slide. So the type 1 arches, where both the DP and the PT vessel feed into the arch. Type 2 is, there are 2 types, either the DP is feeding into the arch, or the PT feeds into the arch, but one of the vessels is missing. And type 3 is where the whole arch is missing. Next slide. So interestingly, what they showed is that regardless, if you, at least in this study, what they showed is, if you do a direct or an indirect revascularization, it did not make a difference in the wound healing rates. What did make a difference is, go to next slide, please. That if you have a type 1 or a type 2 arch, meaning thereby there is a preserved arch which is fed by either both or at least one vessel, the wound healing is much better as compared to when the arch is missing. So I guess the take home from this is that even if you are not able to establish a direct inline flow, if you are able to establish a flow into the arch, that gives you a better wound healing as compared to not establishing a flow into the arch. Next slide. More recently, the concept of woundosome has come. What it kind of entails is, this is from the Japanese researchers from the Olive registry. What they show is that regardless of how you establish flow to the wound, so long you have a post-intervention angiographic blush into the wounds heal better, and it does not matter if you establish a direct versus indirect, you have an arch versus no arch. Next slide. So, if kind of summarizing these three aspects of how to choose a vessel and how to pick up a target, I think if technically doable and within the limits of, like especially in this case, patient, if we have to pick up, the creatinine is elevated. So if you're not using much dye, it is doable. I think the direct inline flow or angiosome-directed therapy should be the target. If that is something which is, not doable, then at least the intent should be to establish a direct flow into the pedal arch. It could be either a AT or a PT or it could be an anatomical variant where the peroneal drains through a perforating branch into the pedal arch. And even if let's say we have a desert foot and none of this is technically doable, everything is closed, at least from the technical standpoint, we should try to establish a good wound blush by any means. Next slide. Another thing which is kind of relevant to this was, I found this study which was interesting. I thought I would mention it. That when we have a CLI patient, we can either have a multilevel disease or an isolated tibial disease, and it's a little counterintuitive that I was thinking that multilevel disease would have worse outcomes. It's actually other way around. There are a couple of studies which looked into that. Multilevel disease tends to dominate. It's about 66% versus 1/3 when there is isolated tibial disease. And next slide. And it's been shown in a couple of studies that people with the multilevel disease in CLI patients tend to do better as compared to isolated tibial disease. How it translates into our patient, she's an elderly lady with essentially isolated tibial disease, even though we saw some moderate disease in the SFA and the popliteal. And so the idea is to open up a vessel so that at least her wound heals, but we'll have to keep a close follow-up so that we get a good secondary patency in this case. Next slide. And just to kind of sum up, as we know, CLI is kind of a cogwheel with multiple spokes, and revascularization is only one strategy into it. And this we follow very closely at Mount Sinai Hospital. We have a multidisciplinary team with involvement from surgeons. We have involvement from our ID specialist, wound care, nutrition specialist. And that is the crux in achieving a good result in a CLI patient. Thank you.
That's a very nice talk, Sandeep.
Thanks, Kaushik.
It's nice, very informative.
So what we've been doing in the meantime is, Vishal and
Looks
I,
like you made some progress, PK.
yeah, I'm not happy. So Vishal and I looked at the calcium, and you can see here we got the calcium as our little barrier. I don't know how that shows to you. Here, when you mag up a little more, you can see. Then we use the confianza to break the cap, and then we advance, and it looks like we're heading in the sort of the right direction, but I'm not certain. As you can see, the distal reconstitution there. But now it looks like we switch to another wire, and now it looks like we're off.
You think that is a distal reconstitution?
I think so. Let's do another shot here, Vishal.
Or you think it's just a collateral, PK?
It might be a collateral, but I mean, it gives you an idea of where we're headed, right? Let's see. I think this is going to be sort of the challenge
the distal
here.
reconstitution was way distal.
It is way distal, but I think you're going to have some islands that you might be able to get into. See, you got an island possibly right there. We got a long way to go. So like I said, our primary therapy is to try to get through this one, and then our secondary would be to try to do the perineal. I just don't like the way this is looking.
Yeah,
I'm going to inject.
it just makes the...
I'm just going to inject through through this catheter to see where we are here.
Looks like we went into the vein.
Might be.
Because it looks too free and makes a weird bend there.
Mm-hmm.
So Sandeep, according to what you said on the data
Uh-huh.
and everything, you think fixing the SFA, popliteal and the peroneal would be beneficial for this patient?
So this is interesting. Actually, I don't know if the arch showed up nice on this images. So
Right.
what we have is the 3-vessel occlusion. There is a long PT occlusion. There is a short peroneal occlusion, and kind of long
got it
or
here.
intermediately long AT occlusion.
Right.
And now the wound is a very classic of AT distribution. It's on the
Right.
middle aspect of the first toe. So, if doable, our intent is, or what Dr. Krishna is trying to do is open up the AT. That will establish the most direct inline flow to that wound area.
Give me the
Let's say,
Fluid,
so the
yes,
second target would be the peroneal, because I don't know if showed up. The peroneal gives a very nice feed into through one of the perforating arteries distally into the arch.
Right.
And PT would be the last target to go in this patient.
Right.
Yeah, so I think here, like, look, we got to give it the old college try here. So we're going to go for this.
Looks like you went into one of the islands nicely.
Well, we'll see. We'll see where we are, and then we'll take it from there. Right now, I'm just switching between hydrophilic and.
So you're using a hydrophilic wire now, PK?
Right now, I'm going with a hydrophilic wire to try to see whether I can
To go into that small.
that little small area that
tweak
we've
there, yeah.
created with the confianza, and then take it from there. And then, if not, we'll just go after the perineal, and then possibly increase the flow into the arch, and then bring her back, and then go with a pedal stick to come back up the dorsalis pedis. Because if we increase the flow into the arch, what'll happen for us will be definitely we'll have a better reconstitution of the distal vessel. So this way we can have a better option of doing the pedal stick. So this is what I'm planning on doing. Let me see how this goes here. So right now this is not a
That
good
looks
situation.
Like a nice cap there.
Yeah, it's really a tough one here. That's kind of where we were, which is not the right place. Yeah, now it's going back into where I don't want to go. It's always, always one of the
You
other.
think it's
right?
one of the branches too?
Yeah, it looks like it. It looks like one of the collateral caps here. So let's see whether we can try to torque it into this one. We had a nice spot there, and then we blew it. Torquer, please. So, at this
Again,
stage,
Vishal, let's talk about we talk about it all the time. I know we have an escalation algorithm. Vishal, you want to talk about the wire escalation algorithm for?
Yeah, I mean, I guess again it's more of a personal preference, but going between hydrophilic and the stiffer wires. First of all, I mean, to begin with, like what PK is doing is like trying to find the channel. If it's a hibernating vessel, try to see if you can go hydrophilic wire, which probably finds lumens faster than any other wire. But in case we end up in a roadblock, then usually I try to switch over to a stiffer section like a confianza to begin with.
Right.
And then probably if you have to go up, you can use an Ostado or even go up on an 018 wires if it needs to be escalated. But again, switching between hydrophilic, finding the lumen, then going across the cap, again finding a lumen, because in these cases it's not like a hard pipe is completely blocked. You'll find islands like PK said of occlusion, and then lumen, then occlusion, then lumen. But so
Come off,
I guess we have to go
That looks like a good cap pick.
right.
it looks like I was able to find something in there.
Right.
Unfortunately, there's not enough calcium, but we'll see. We'll see where this goes.
No problem.
Now probably switch to a
Yeah, switch to a
confianza.
Yeah, probably keep the catheter right at the cap and then switch it to a confianza, I guess. Push it down even more,
Yeah, more.
a little more probably.
I just don't like the way that's kind of pointing, but we'll see. Say the
Same
same
thing.
thing. Just broke into the other thing there.
Yeah, that's probably the way. Because the way it's going all laterally, it's either a branch or.
Do you want to see if you have something just like you are having now, like a branch with a stump knob, or you might want to go down with the catheter and then manipulate it?
Well,
Just that bend makes it a little uncomfortable, but that's not how the AT usually runs in.
yeah, that's the problem right here.
PK, would you take a picture
Give me
from the
catheter.
catheter at this time?
If I can withdraw blood, yes.
Okay.
Yeah.
That's the confianza.
And we can't withdraw blood, so no.
That's fine cross. It takes time.
If you pull back a little bit and then with it,
Yeah, no, it's
just a little bit.
No, we're withdrawing some blood.
Okay.
probably a branch.
Maybe a vein. And I think that's what people need to understand, that You know, you can be in veins.
So it's very easy to go, in generally as PK is just telling, it's
Roadmap.
very easy to get into the veins when you're doing tibial vessels, because there are 2 veins for every single tibial vessel. They run very close in the same bundle. So it's very easy to run into a vein. I think like we see there, PK, looks like his PK going into, are you going into that collateral again, right,
Yeah,
PK?
it's a collateral.
I don't know what that is. We'll figure it out.
It's a different color.
It's a different one, right?
Yeah.
Looks like a different collateral.
Yeah.
Or is that come off roadmap, or it might be a perf, which we'll see now. Nope, it's not a
Doesn't
perf.
look like a perf, it looks like a, so that's a good sign. But you're seeing some staining there.
Yeah, that's what I was saying.
Staining is okay.
I mean, that could be a vein also, so it's possible. But
Yeah, the way it's. No.
No, it's
Where
not a
it's going.
perf. I can
Ah,
tell you
it's not a
that.
perf.
no, it's a vessel.
Yeah, so
It's
that's
a
The
vessel.
question is it a
Question
vein or
what-
an artery?
Give me a torque. So we're going to try to keep going here.
All right, so so PK, if this is not possible, are you going to take a pedal stick or?
No, not today. Our idea today was to talk about angiosomes and see how we can use them to help guide us and what it means to all of us in terms of how we can choose the vessel.
Right.
So there you go.
There it is.
So that was just you know, part of the support thing that we talked about. You know, now it looks like I don't know where I am again. But you know, every now and then you might be able to switch to a
Yeah.
a hydrophilic
That looks
catheter
pretty
here.
promising, no?
Well, I don't know. We'll see. We got a long way to go. I've been fooled before, believe me, as you have. And we'll see. It's just too medial here.
And the movement of
We'll
the
see.
wire looks like it's
Yeah.
more subintimalish.
So Karthik, I remember you talking about the loop in below the vessels and you're not afraid of it. So let's say if you don't find a channel, would you start proximally where you know you're in true lumen and loop it down?
So from here to the, I wouldn't mind taking a loop from here to DP, Vishal. This is not a long segment loop, so it's okay. I usually try to keep the loop to the level of around, that looks pretty positive.
Well,
Yeah.
I usually, as long as it's less than 10 centimeters, I'm okay with the loop.
So you know, like, look, guys, you might be in the vein, you may not be in the vein. You know, it's like, you know, I wouldn't worry too much about it. Right now, you got the best nurse in the world, Elizabeth, right? So you just go ahead and push and let her worry about the perforation. All right. So she'll tell you when.
yeah, she
when
can hold the
she
leg
can
all
hold
night
she can
long,
hold the
so
leg.
it's
She's
okay.
great.
Yeah.
So let me go up top here. See, this is the problem with this technique. I mean, we like it, but the problem is now you see I'm out of catheter space here.
Right.
So now the issue is this is what is it, 150, and I
135.
so in the 135. So now I'm gonna have to advance this catheter over this catheter. So show me above. So I'm gonna see if I can
That's
get
an
this down.
035 catheter, you think?
Yeah.
Yeah, you know, it's a little bit of snow plowing, but that's okay. You know, we're gonna try to get down here. Now show me down below, Chief. So now this is gonna see now that that's not a good thing. So let's see where we are here. See, without support, it's very difficult. See that?
So, Vishal, what do you do with the loop technique? Do you take a loop technique? Or?
Well, I mean, that's one of my almost last resort, because if I know I'm going to abort or it's almost
that-
at the end where I'm running out of options, yes. I mean, I would probably take the loop technique and try to see if I can connect the dots at the
So
end.
your patency rates are not the greatest if you have
DSA?
a long loop technique. If you have a long segment of dissection or a
Right.
subintimal plane in the tibials, your patency rates are not the greatest.
No.
Correct. That's the real issue. That's what I'm saying.
Yeah.
So eventually, I know we might be angiographically
The
successful.
recoil rates are pretty high. What do you think, PK?
I think you got to go ahead and do it again.
I'll do it
Well,
again.
we take the loop when it's appropriate. I think right now we're just really. I think even if I got a loop, I would be uncomfortable because I really think that I'm not in the vessel right here. You know, I like the kind of situation where I'm heading, but you know, obviously I'm very far away from anything remotely resembling a vessel. So I think I'm going to go here with the XT. I'm going to go with the
hydrophilic
Fielder
wire
XT.
again? Okay.
I'm going to go with the Fielder XT here and try to do it. Now, this is the problem with this right now.
There's a new Fielder XT.
Now, right now, we're running out of space with this catheter. So we got so this may be an issue where Vishal and I may have to lose position because of the distance that we're dealing with here.
Why don't you take the?
No, what we'll do is we'll put the wire down, take the catheters, both the catheters out, and then reintroduce our
I mean,
or the
it's something
micro
that we
catheter.
didn't want to do, but we're gonna have. Looks like we're gonna have to do that.
Okay.
We don't have to lose this.
Give me
if you're, I mean,
Torque, I guess?
my understanding is, why couldn't you use a 5 French long sheet? That looks like it's a kind of a dissection plane.
it contained dissection.
Yeah.
So at this point, I guess you have nothing to lose. You can take a loop and go, no, PK? It's not.
We'll see how it goes.
It's not a long segment.
We
Looks
can
like
always
it's
pull
a-
back and redirect. There's multiple things we can do.
Yeah.
I'm going to ask Elizabeth to turn off the Angiomax like we usually do at this stage. And I think part of that advantage is having a little bit of, the ability to go ahead and
So
Come-
we are
come back.
talking about lack of support and everything, right? Vishal, what do you think about antegrade access?
I mean, yeah, it's always a good option if the patient's habitus allows it. Then antegrade access is a very good.
show me,
the-
Bob. I don't
Very
like where
good.
we are.
Yeah,
that
that's
big
a
loop.
that's a very
loop
big dissection plane.
Yeah.
That's a big loop there.
That's our branch. Right
So
there.
that's
Yeah,
our
then
branch.
antegrade access is always a great idea to get you good support.
So this is the thing I don't want everybody to get worried about. Yeah, you may have a perforation or whatever, but it's not the end of the world. You just stop the Angiomax, and then you go ahead and try to go in a different direction here, and see how you're feeling. Patient is feeling fine, and I think that's the
Do
whole
you think
idea
it's a
here.
perf? I think it's more of a contained
It's a
dissection,
dissection.
PK.
It's a dissection, yeah.
Yeah.
I mean,
Tight.
people get all crazy with that, but we'll see. Show me above. So I think I'm going to have to go with another wire here. I'm going to come even further up here and see whether I can get, and sometimes finding a loop is not the easiest thing to do either,
Right.
especially in the tibial area. There you go. That was a little bit better.
That was the.
I kind of
Right.
like
That looks more. Yeah, that is
yeah,
more like
let's
a
see where
plane.
this one goes. Nope.
That's the one. That, yeah.
Okay, now
Yeah, that
if I
looks
can get a
so-
loop, I'll be happy.
It'll make
Yeah,
that.
There you go. Well, we'll see. We'll
It's a
see
big
what-
loop, but.
Oh, we'll get it
It's okay,
down. We'll
once we
make it
get the
smaller.
microcatheter, yeah.
We'll get it smaller. I just don't know if that vessel is going in that direction,
You're losing the loop. Okay.
No. See? That's what I'm saying.
That's more like a vein there. So
Yeah, I agree.
yeah,
There.
Nope, same thing.
that's a vein.
thing.
Yep.
So let's come back up here. How's she doing, Liz?
So so Vishal, you asked about loop. So
Right.
the way I do my loops is like the loop which we having right now. That's a big loop. I categorize the pedal loops as O loops. So the loop should be more of a V than a U or a O. So the smaller the loop, the better it is. The narrower the loop, the better it is,
Should we do?
because you're causing a less amount of dissection.
That's true.
Like the loop we are getting right now there is more like an O loop. That's a little bit difficult to get through into the distal vessel because it creates a big dissection plane. And also when you start ballooning, you start creating a bigger
Right.
tear.
Get me off DSA here, guys.
Yes, it is. Okay, inject it.
No inject.
Oops, sorry.
No, it's okay. You seem to
Looks
be
like,
off.
like a little bit of small extravasation there. Peter.
No, I don't think it's extra. It was there before. Give me confi heads again. Let me try one more thing.
So PK, what do you think about doing that peroneal? You think that that's going to heal the ulcer?
Well, I think at least, see, the plan here is not to heal the ulcer with the perineal. I think the plan here would be for me to come back and get pedal access. To me, I think at this stage, I want to get my gains as much as I can. Right now at this stage, the gain here would be trying to get into the perineal, open the perineal, and then see how, and then open my SFA, and then see how the flow is into the foot. Now that may light up the arch even better for me to give me a better target to be able to come up, and it may open up flow into this segment of this dorsalis pedis, opening up some islands for us to give it a shot.
No, with the
So I think
collaterals.
I'm going to give one more shot here, and then I'm going to go after the perineal. We'll talk a little bit about antegrade wire escalation in the perineal. It's a shorter segment, should be able to break through, I hope. If not, then Bray, I need pressure on this catheter here. you know, and then we'll
So
decide.
PK, in the beginning you said, you know, if the ulcer doesn't heal, you would go for a transmat, right? At least you would give enough flow for a transmat. So you think peroneal is enough for a transmat?
Well, I think that it's definitely going to help.
Okay.
You know, I think it's going to help for sure. You know?
Yeah.
No, did the same thing.
Popped in there.
So it's going into the same plane
Let's see,
again.
let's see how this goes. Well, maybe not, I don't know. I've been fooled sometimes, you know, you think it's in the same plane and it's in a completely different plane. Sometimes it's worthwhile to get all the way down there and then decide where you are and then figure it out. See, this is not a good sign. See,
That's
well,
too
for
much of a-
those at home, this kind of wire movement is not a good sign. See?
Yeah.
You definitely want to be able to try to get it into the sort of the line of the DP or the AT. And right now it's definitely not behaving like it's going in the line of the DP or the AT.
That's a pretty big plane.
Yep, no question. Definitely not. We're somewhere else. We're somewhere in Dodge here. And you know, you have to be ready to balloon tamponade if, God forbid, you perf or something like that, you know. See, this is so free flowing. You see this?
That's a vein.
We're somewhere in the middle of either in the vein or not,
That looks
which I'm
like it's a
okay if
vein.
we're in the vein, you know. I'm okay if we're in the vein. I'm just gonna, I don't know why this lady is placed so low by our team, because I can't even go lateral because my assist is in the way. So, all right, give me a regular injection, guys.
Yeah.
Chris, why can't I go lateral because the assist is in the way? I can't even go lateral. The assist is hitting her. She's got to be higher up. She's not even that tall. Well, then why? Something is different because I can't go lateral.
So Vishal, tell me about your stenting techniques, infrapopliteal vessels, CLI.
Well, I mean, again, if it's a long segment, I usually try to keep it very focal if I have to. Usually try to see how
Ready?
the PTA,
Inject.
how the PTA result is. Most of the times the PTA results, if it suffices and there's good blood flow, if the patient, let's say, is going for amputation, we just leave it the way it is. Or if not, inject it one more time. Then, of course, I like to just do
DSA, please.
stent more focally where the maximum dissection is to improve the blood flow, make sure there's good blood flow all the way down.
Okay. Do you ever stent below the level of the lower 1/3 of the leg?
Usually try to
inject.
avoid to unless it's the major dissection or major flow limiting stuff, and I know there's going to be a huge recoil and with no benefit. In ulcer patients maybe, but usually don't.
Okay.
I think I'm
So
going to go after the perineal here now
Yeah.
at this stage.
I think
I'm
Right.
way up here. I'm kind of in no man's land. A little disappointed with how this is working here, but let's see.
I think
Show me
once
above.
you, as you said, PK, once you open up the peroneal, it might open up a lot of collaterals and give you islands to work on. Here you're flying blind. I mean, that's a long segment of blind. You're going about 30 to 40 centimeters of flying blind. So
Mm.
Yeah, maybe do the
and with some calcification in the vessels, but it's
yeah, but here sometimes calcification is your friend here in this because we don't have one, so
Yeah, see, it's just going lateral.
yeah.
like going into the vein.
Because now we don't see much of a reconstitution in the DP. I mean, I think you see it, but you don't see much of a flow. But once you open a straight line flow into the peroneal, you might have a better idea of where the DP is. Or
I'm just going to keep trying here.
Vishal, how many stents do you limit yourself to infrapopliteally?
Uh,
1, 2, 3.
Maybe 2. I mean, I don't have a real number, but I've never done more than 2, honestly. So
Okay.
Let me come up here. Show me above the shot.
Pick
So I
it.
think it's important here when you decide to stop, come back up and then take a shot on the DSA. Ready?
yeah.
So you just want to take a good picture, inject, because you created obviously a big channel. Let's see how it looks. So a little bit of a perforation, you know. So what we're going to have to do here is probably put a balloon down.
balloon,
right? Give me a fielder wire, guys.
new fielder.
So what we're going to do now is put a balloon down. And then if we need to, let me see, give me a 3060 balloon. So now the thing that you have to watch for is obviously pain in the leg. I bent this wire. Give me another wire.
So
give me another fielder.
So we stopped the Angiomax. Right?
Yeah, that's why I
Don't
stopped
move
it
on.
ahead of time.
Angiomax, that's right.
But I think at this stage, Ray's going to walk over and squeeze her leg.
So it's
So it's the anterior compartment, so you got to be a little careful.
PK, you want to fluoro and see if there's staining there?
It may not be. You're right, but I think there is going to be staining there. Not really.
Because I don't know if it's really a perf or a vein.
Remember, the thing you want to look for is pain.
Right.
So Lizzie's going to squeeze.
Because the patient is not moving the leg. So
Yeah,
I don't
I
know
agree.
if it's really
But remember, the
a
leak
perf.
is going to be very slow
Correct.
in the anterior compartment, and Lizzie's going to look for any hardness. I want to feel the whole tibialis anterior muscle from the ankle all the way up, Liz, sort of like a massage.
Yeah, because your wire didn't behave like it was free.
Well, it was free. It was free at the end.
Okay.
But, I think at this stage, what you want to do is at least keep an eye.
Because I don't see any staining there at all whatsoever. So
Well, no, I agree.
Right. What one could also do is essentially is put a blood pressure cuff around it and inflate it, so that gives us a control of
Anything,
the
Liz?
external tamponade if you're
Okay.
really
yeah, I think
We'll watch her.
concerned. But
you're going to put a balloon into the AT,
Right.
PK?
You'll probably open it up bigger.
Yeah.
That's another potential. Show me above, guys.
But why do you want to do that, PK? Why can't you
I
just
agree.
put a blood pressure
No,
cuff,
I think
go
we
after
can
the-
watch it. We can watch it
Yeah.
at this stage.
Open
Ray's here. Ray'll walk over and check it out.
Yeah.
So I pulled out that tertiary kind of situation here, and now I'm just going to go with fielder and go with my fine cross, and start
Yeah,
doing the.
Peroneal. And then
Try to do the
yeah,
perineal here.
Then we can always take pictures and see what's happening. If it's
Yeah.
a vein, it will shut down by itself, right?
Well,
After some
generally
time.
they tend to be self-limiting.
Right.
So
if you're in a
Well,
vein,
it's a
then after
CTO,
some time it's
so
going to shut
it's
down
not
by
a-
itself.
okay. So let's see here. Roadmap.
So PK, your stenting techniques. How many stents do you limit
no.
You want
for
a roadmap?
infrapopliteal vessels?
How many what?
How many stents do you limit to?
Whatever it takes to keep the vessel open.
Nice.
I mean, I don't think there's really a limit there for all of us in terms of what we're doing.
But I mean, we still talk about patency and thrombosis, right? So
Yeah, I mean, thrombosis is, I don't think, as big an issue as is patency.
right.
I think that, you have to watch these patients closely, obviously,
You want the-
see how they're
you want the
doing.
fine cross?
Yeah, let's put the wire fine cross on,
Yeah.
and then put the wire. I think that here, it's a shorter segment, we'll be able to break through, and then we'll see whether we can do something transcollateral on the way back.
So PK, just to be devil's advocate, let's say you put a balloon, right, in the AT when you have a perf, and the perf doesn't stop. You still have extravasation. What, you would coil the vessel?
Yeah, I'd coil the vessel, absolutely.
Okay.
But I think at this stage, that's going to be my last step thing that we're going to do. What we're going to do is really do a balloon tamponade first. And then if they're still bleeding, then we'll obviously do a blood pressure cuff along with the balloon tamponade the way Vishal suggested. Hold the wire, guys.
Yes.
And then we'll go ahead, and then after that we'll decide whether we need to coil. That will just be the last situation.
PK, would you ever revascularize? I mean, would you ever try to revascularize the vessel after coiling?
I'm sure it's possible. We've never had to do it off-road map. We've never had to do it mag up here, guys.
Just as an option. I just want to know.
Oh yeah, it's always an option. Off coronary.
Yeah.
Okay. So now we're going to be at this level here.
Let me
Let's
follow.
see whether we can. Show me down.
I think you are in that channel. That's your stump.
Okay. So hopefully the field of wire finds our channel here.
Why a fielder wire, PK?
I'm just trying to see if there's any hibernating microchannels.
Okay.
Doesn't seem to be, at least. Give me a roadmap here, Rochelle. Inject. Liz, feel the leg in a second.
When you have a short CTO like this, PK, do you think using a hydrophilic wire would create a plane for you?
It could.
It might make it difficult for you to use a confidence
anything.
escalated to
One more time.
confidence
Hold
next.
on. That's fine.
DSA, guys. What's that?
DSA.
I'm saying if you have a hydrophilic
Hang
wire
on, Liz.
for this kind of a short wire, it might create a dissection plane for you. It might become difficult for the confianza, right?
So don't
Yeah.
move. I'll give you a roadmap there. with that.
Possibly. I think we could
Hold
just
on.
go right through. Give me a confianza here, guys.
New
Yeah,
confianza.
because it's really short CTO.
Or
I
give
think
me a
confianza will
win-
just
a
pop
win.
through it.
When, I have XT also.
No.
Okay, here's your roadmap.
So if you see now the perforation is already better.
Yeah.
So just kind of watch it, turn off the Angiomax, let it tamponade itself.
Yeah, I mean the good point is it's a CTO, so there is not really any blood flow going down, so it should technically close by itself. The only concern you have is if there's continuous inline flow. In this case, there's none, so it will should technically shut off. So that's the good thing about CTOs and perfs, I guess.
Can I have a?
Field.
Yep.
No, XT. That's XT.
PK, another thing is AV fistulas. You create AV fistulas in the CTO vessels. You have
Now
anything
the
to worry
roadmap is
about?
gone.
No, I think AV fistulas all heal up on their own.
Okay.
I don't think it's an issue. And you know, in the old days, they used to create AV fistulas surgically to help heal wounds. So I think at this situation, you know, I wouldn't offer
You
a
wanna
Mephi. I
offer-
don't need it.
okay.
I think in this situation, I think I wouldn't worry too much about the AV fistula. I think that will close. What I'm more worried about is perforation
Let me give you a cap.
in the anterior compartment.
One second.
Because Torker guys, because I think perforation in the anterior compartment clearly can lead to tamponade much more than perforation anywhere else. So you know, I think at this situation, you know, the idea here is we have a backup vessel. So once we cross this, hopefully, we will be able to then figure out what we're going
That's
to
a
do.
confianza PK uses?
Yeah.
This is a win.
Win.
It's a wind wire, you know. Hopefully it finds the plane. Obviously a lot of resistance. You know, you got to be a little careful here in terms of how it goes. So it's not going to be
It's
enough
not
to break.
torquing at all.
No, you know, I might have to go with a Asahi 21014. So give me that Asahi wire here, guys. Astado 21.
Astaro, 20,
Okay.
30.
So this is not enough. And I think this is where what you said, Karthik, is important, not to create a dissection plane. You know, be careful, figure out, because now this is your lifeline vessel, and you need to cross this carefully.
Yeah, because there are a lot of bridging collaterals. It's very easy to create a big dissection plane here. And once you create it,
And the advantage here is also to maybe use a little roadmap locally
Yeah,
to see where you are at.
agreed.
Say there you are. So at least now you have a
Perfect.
beak to aim for, you know, and then take it from there. So that was a collateral in which the field of
Right,
whatever
the-
command was falling into.
Right.
So now we're going to go with a smaller curve on the Asahi if I can.
I have it.
Would you take a roadmap from above also, just to? See?
You can't see much.
Well, you can kind of
Try
see, you know, you kind of see where you want to go here. So, you know, these are the toughest when you have a blunt CTO like this with a collateral coming off. This is probably the least favorable cap for you to be able to get through. And this is where sometimes the 018 wires may help as well. So let's see whether we can just get a plane started and come. So hopefully
I
that's
think it broke the cap.
well, I don't know. We'll see.
Looks like it did. It just gave through.
There it goes.
Felt like it.
This is the area you got to be a little careful. So now I'm going to ask Vishal to inject from above
Yeah.
because you definitely don't want to increase the plane by doing a dissection. Oh,
A roadmap.
DSA guys.
Oh, yes. Hold on. Okay. Yep.
So it's much more favorable here. So we're just going to, you know, I'm going to ask just
Looks
keep
like
going
it's in the
straight
right
here.
Direction.
Maybe Ray can push the catheter down a little bit. It's
PK, at
off,
this point, you're
off a little bit. Ray,
you're in that small vessel.
advance.
So if you advance a little bit here, you would want to take this wire
The
away and put a
filler.
hydrophilic wire and
Yeah.
try.
Possibly, but you know,
A
it's not moving freely. I can tell you that.
Yeah.
I mean, we're truly in a dissection plane here.
I
Now
don't know,
let's
I mean,
take
it
another
might
picture.
Not make that bend, right, for you?
It'll make it. I mean, I think it'll definitely make it. Ready?
Yep.
Because it looks like you have a channel there. So
No, it's heading the right direction.
There. She's right on top of it.
It's heading the right
It's actually
direction.
there. Let it go. Oh, there. There. So he wants to go into the branch.
No.
Yeah, it's the branch.
No, no, that's not the. That's deflecting.
Take the hydro.
Let's take this catheter down a little bit. Okay. Give me. Let me see here. Wow, this is tough. Let's take another picture here. This
Very
is definitely not
fibrotic.
an
Very
old,
fibrotic, right, PK? It looks
very
like
calcific,
it's very
fibrotic,
fibrotic.
fibrocalcific. We look okay here. I think this is going to slip in. God
Something
willing.
it was trying to go into.
God
the
willing.
right
Yeah, it
there.
was definitely, no question.
That
Yeah,
movement is.
Yeah, well, it's restricted for
yeah,
sure.
exactly, right.
Yeah.
That
Well,
movement
it's
is
very
not a very
fibrotic.
good movement for a wire, PK.
Huh?
You would still continue with this wire?
I probably would here.
Yeah.
Looks like it's creating a plane there, right on top of the vessel.
It might be.
Yeah.
That's pretty okay, but just that.
Nah, it's not going.
Yeah, just that movement is not.
All right, give me the other wire back now.
I have XT or which one?
Not the
The
XT.
filter,
XT.
plain filter?
No, the
The
give me
win?
the
Win?
the
The
win
win.
now.
Okay.
Very fibrotic plaque.
Very much.
Yeah. you
Like
can
we
see.
said, we weren't kidding around when we told you this is difficult.
Yeah.
Even if you have to take a loop and go in, I think it's okay, PK, because you can stent this segment.
Well, I'm going to stent. There's
Yeah.
no question. I mean,
Yeah, it's a.
this is not a case for atherectomy, in my opinion. This is a case you need to stent this thing.
Yeah.
Look at that. Look at that.
Oh.
Ooh, that's a big plane.
Well, no, it's a dissection. It's not a perf.
It's a big plane.
It's a
you-
big plane. It's
PK,
not
you want to
expanding.
you want to pull it back and restart?
I'm probably going to right
Yeah.
there. Look at that.
Wow.
Max
That
is
is
off. Liz?
surprising.
Max off.
That is very surprising.
Oh, it's tough. These are not easy cases.
For that much amount of movement and that much linearity, it's impressive.
Do you want to start back from the beginning? PK?
We are above now, Karthik.
A little- okay.
Yeah, of course. This is the win.
Win.
Yeah.
Okay, give me the XT now.
XT.
No.
That's more favorable. That's nice. Much better.
Kind of in that plane.
Yeah.
Yeah.
Yep, give me the XT.
Yeah. That's on the
XT
table.
is right here.
Mm-hmm. Let me try another wire here. If not, give me an 018 wire next. Now give me an 018,
That's fine.
Connect you want to use?
the Terumo M.
Give us them. Old. Yeah, we need over. Yeah.
So the cuff is on, Ray.
No. I don't think this is a perf card. I think it's not expanding.
It's
No,
a
no,
dissection.
I'm just saying because of
Maybe
the AT. I'm saying.
Nah, I
that
think
was-
we're okay there.
No, no, was the cuff on or? it's
No, we
just
never put it
resolved-
on.
Oh, it
No.
resolved by itself.
It's
Okay.
self-contained, self.
That's it. That's it. You're in.
That's the beauty of the XT. Take a picture, guys. Let's make sure we're in the right spot.
It's definitely in. The way it moved in.
That's why sometimes it's worthwhile taking a hydrophilic picture.
Yep.
Yep, beautiful. Yeah.
Yeah.
Well, we created so many planes. There you go. Good.
and we
So now
went,
give me a
Spartacore.
Spartacore wire.
and we went right through the
We
middle
went right
of the
through the
dissection.
middle of that dissection. So again, look, there's so many things you can learn from this case. You know, don't panic because everybody's going to perforate. You're going to have microperforation. You're going to have things like that going on throughout this lesion. Judiciously use your anticoagulation. Check now I'm going to ask Liz to squeeze the leg again. It's been a few minutes. If there's any change in the leg, then you know there's a problem, and you might have to put a blood pressure cuff in.
Okay.
So remember, also the other thing is going to happen is when you get straight line flow down this vessel, it's just going to completely steal from the other vessel and likely close off the other vessel. So you know, it's just, you just got to make sure that you're not having any issues going on while you're doing this. So there's going to be a problem. So she's going to squeeze. Hopefully she doesn't go out. She's sleeping. She's enjoying the massage. So I don't think it's anything. Anything, Liz? Okay, good. Show me down now. So that's Liz's hands. Oh, there's a whistle from the crowd. And now we're going to, now give us a balloon, guys.
Somebody just emailed me saying that Dr. Krishnan is fluoroing the nurses. Oh, that's interesting. It's probably going into the, probably get the catheter down.
Give me a little picture.
Dye?
Yeah, dye. I'm going to take a picture through
I
the
think it
catheter.
probably just went into
Yeah, just a
one of
little
the
loop.
branches. Yeah, probably went into one of the branches.
DSA, guys.
I see you have some blood flow there, right?
Yes. Oh, that's just.
That's the small.
Small branch.
So you just gave some dye and just pushed the catheter down.
Nitrite? Nitrite?
What wire do you have now, PK?
Just a
Starter.
Spartacore.
Okay.
Give us a balloon.
Rio?
No, 3060 is fine.
So you're going to probably end up putting 2 stents.
Actually,
right?
3040, Ray.
Yeah.
What
Just
kind of
focal.
stents would you choose here, PK?
Drug-eluting for sure.
Yeah, but you would choose 3.0, 3.5,
Huh?
3.5?
I think we'll probably a 3.5 or a 4.0. So now we're going to go ahead. Again, don't worry about that staining.
Fluoro for
60.
me. Just
Yeah.
The
Give me a
angiomax
40.
is still off, right, PK?
Yep, we're going to turn it on after we
Hold on.
balloon.
Okay.
Just want to make sure my wire is there. Yeah, the wire? Okay.
3040.
So you're comfortable with the sheath and angiomax being off?
100% because we watch our waveform.
Okay.
And so as long as our waveform doesn't get damp, we're fine.
Okay.
So Liz, you can turn the Angiomax back on now.
And usually, the Angiomax stays in the system. Even if you give bolus Angiomax, it stays in the system for 20 minutes or so-called therapeutic. So I think we're still, yeah,
I
we're
thought the
almost out
half-life
of the
is 2
borderline.
hours, right?
2
Yeah.
hours, yes. 2
No,
hours.
the half-life is,
Half hour, 30 minutes.
30
yeah,
minutes.
exactly.
But
So
the
that's why
effect
when you
stays
give a
in for
bolus,
2 hours, so
4 half-lives.
4 half-lives.
4 half-lives, 2
All
hours.
right.
It's like around a 60 millimeter segment, so 238 stents probably.
Well, let's see. Okay, let's go up right here.
Going up. Thanks, man.
Yep, let's go up right across. So we're just going to balloon this first. Now, I wouldn't atherectomize this, gang, because of the perforation.
So the data on DES and infrapopliteal stenting is pretty good, right, PK?
Yeah. Oh, it's
Patent-
phenomenal.
The patency rates are reaching around 92-93%.
There it is. Well,
So the Yukon, there are multiple trials.
Multiple trials.
There's
Yukon.
Yukon, Destiny.
Yes.
There's Achilles.
Achilles study.
There's multiple trials showing that it's quite good. So here what we're going to do is we're going to go ahead and do it. We may atherectomize the proximal popliteal and then maybe DCB it, but we'll do that offline. I think at this stage we're already at 9 o'clock. It took us an hour to get this far. So we're going to just leave this up in case we open up some micro channels here and then decide down.
I think it's a very tough case.
Oh, it's
as
a very
you said,
tough
I
case.
think,
There's no
you know,
question.
Somebody
I
up
mean, it's
there,
a tough in a lot of situations. Go up here.
when you said it's going to be a tough case, somebody up there said yes. So
Oh, there's no question it's a tough case. 10, 12,
yeah, I'm going slow.
So DSA now, change it to DSA. So what you want to do in this kind of situation is you may open this up when Dr. Kapoor is ballooned, so down. So what I'm going to do is pull this back into the popliteal and take a picture. You must be fully ready to see a Hiroshima or something like that, and like a big explosion here. So we will inject, and we'll see how she looks here. You know.
Oh, it looks beautiful. The
So
negative shadow.
good
Just one
flow,
segment
right?
there.
That looks very nice.
There's a
So
segment there.
proximally, we have to go ahead and balloon. So we're going to balloon over here as well. So let's go up right here, guys. So, you know,
I think if you pan up a little bit, PK, I think you're missing a segment. Yeah.
Yep.
Probably a little bit more. Probably pull back balloon a little
down?
bit more. Okay.
I just was focusing on the perforated segment. Hold on. Another picture.
Yeah.
Yep. So the whole area needs to be fixed and stented. So we're going to go ahead. Give me a 3.538, guys.
Right there, I guess. Yeah.
Yep. Go up.
So you're going to end right after that bifurcation, right?
Probably. Yeah. There's another lesion there.
Right there, right?
So down. Give me 2 3.538 Ziences.
You got it.
PK, in this sense, would you stand from distal to proximal, proximal to distal?
Always distal to proximal. I mean, you know, you're so far away from that area that you want to make sure that for you, everything is going to track. You know,
Right.
we've had times where Vishal and I have had trouble tracking stuff. We've had to use guideliners, stuff like that. So I think that definitely you want to be able to do this from below up rather than above below.
Okay.
got it.
So always stent the
Makes
distal and then come proximal. You know, this is a CLI patient. Obviously, patency is very important in this lady. Plus, you're not fully done the angiosomal revascularization.
My
Your
wire.
wire's
Wire
back,
came
which
out.
is fine. Again, it's Vishal doing this to me. You know, you haven't done the angiosomal. I'm having trouble up top. Show me up top. So sometimes, you know, these stents don't want to track as easily as you want to. So whatever reason, there it goes. So it's the arch that was giving me trouble. So this is what I mean. If you have trouble tracking it in the arch, this is already going to be an issue. Okay. Who is it? Alfio. Okay. Lacini.
Yes.
Okay.
Hold on.
You can answer, Liz.
Okay.
Inject.
You might
Yeah.
want
See
to,
much.
I don't know why
Or
they
you might
changed
want to
it
push
to
the wire
not-
and pull back the stent and take a picture, PK.
Yeah, probably. I would probably pull my stent
Give me
back.
a roadmap.
Yeah. Hold on.
Push the wire down a little bit more.
Roadmap.
Mm-hmm.
Yes. Problem is distally there as well.
Probably go down to the tip of the wire, almost
Yeah.
to the level of the tip of the
Yeah,
wire.
that's what
and
I would
start
do.
stenting from there.
Okay, let's go up
Yeah.
here.
Yeah, right there.
A bit more. Yeah.
Too much, I think, PK?
That's okay. Go up.
Going up.
This is 4 PK?
3.5.
3.5. Normal, nothing.
Yeah. I have
That's the spot. That's why it was.
just 10,
Nice.
yeah, another 3.
Down. Go up again. Down. So now we're going to do another 3.5 up top.
Let's come.
You might have to put 3 stents.
Oh, we could use a DCB.
Hold on. Okay.
In the TP trunk, you're
Yeah.
saying?
I mean, one of the things we've learned is that DCBs are very safe in CLI. I know there's no level 1 data for us to say that it is or it's not, but I think at this stage we can definitely use DCBs. We've been using a lot of them in CLIs with good results, with no amputations in all the cases
But I
that
thought
we've
the
done.
data from Europe said, I think Graziani's data, right? Dr. Graziani's data said CLI intrapopliteal DCB data was not the greatest.
No, actually, you know, there's an ongoing study right now with Medtronic. They're looking at their impact below the knee in a pilot study. Lutonix just finished their trial here in the U.S. So, you know, I think that's all old stuff from the Impact Deep trial. That's still a lot of scaring a lot of people. But I think at this stage we're ready. I think it's ready for prime time. There's obviously multiple randomized controlled trials ongoing as we speak. So I think this is we're gonna
small
need
test.
something other than stenting. No, it's
just-
fine. Go up.
Oh, we go up? Okay.
Mhm. I just want to get that overlap. So for the non-interventional cardiologists out there, I think it's important to have overlap of DES just slightly. You don't want to leave a gap because that's the area where the restenosis generally occurs down. So if you're going to use multiple DESs, make sure you actually cover the entire segment without having a gap. And then we'll decide what we're going to be able to do here. Go up here, and then you always want to get the overlap with high pressure to try to go ahead and get the full expansion of the DES down. Okay, good. So now you've covered this. Now we're going to look at the proximal segment, and then we'll decide. Ray, you want to check on 4 just to see what's going on? Okay. Okay.
Good.
All right.
There's a short segment there about
Okay, show me
segment of
above
about
now.
20,
Okay, DSA.
Yes, sir.
probably more than that, I guess.
How much dye have we used so far? Grant is elevated. She's a CKD patient.
Yeah, we got to stent that. Everybody
Yeah.
sees that now?
Yeah.
So give me another,
Another
what, 38?
38, yeah.
No, 38 may be too long, huh?
38. Easily
No, it's
38.
not easy 38.
Easily
Yep,
38.
38. Yeah, give me another 3.5, 3.5, 38.
38 might be even a little bit shorter for you, sir.
No, I think we'll be okay. No. Hopefully it'll be enough. I don't think I think if it's too big for a 4.0 DCB, so it's an LED. But it's too big for a 4.0 DCB. Oh, okay.
But I think if you come up to the level of the TP trunk, you can still put a 4.0 and do an overlap PK. I mean, do a low inflation and do it.
We could. I
it
think
should
at
be
this
okay.
stage, let's secure this with another
Yeah.
stent, and then let's worry about that. This is really a non-compression area for us. So this way we have good flow, and you can see now there's barely
We
any
probably
flow
need another
in
one.
the anterior tibial.
38 is going to be short.
So again, it's a good case for us to demonstrate these things. I think when we're offline, Dr. Singler is going to go ahead, fix that SFA for us, and the popliteal like you talked about. And then after that, we'll go ahead and be done with it. I think the important shot is really going to be the foot shot now to look at that dorsalis pedis
Yeah.
to see
I'm
where
pretty
we
sure
are.
We should have gotten a
And
very
then
nice collapse.
maybe next month we can bring her back for our live case from the foot and see how that works. I mean, one of the beauties in the symposium is that we'll be demonstrating all sorts of accesses. I know we'll be demonstrating the pedal access as well. We've got a new Philips ultrasound machine that's due to arrive next week. So we'll be coming out of the dark ages here at Sinai, and we'll be having a real ultrasound machine to be able to get pedal access and demonstrate these things. So at this stage right now, we used to still use a lot of fluoroscopy, but hopefully that'll change as we go forward.
PK, how do you follow these patients? Vishal, how do you follow these patients with infrapopliteal stenting?
Well, these patients, we at least what we do here is we give 1 year of antiplatelet therapy. We'll follow them with the same protocol of ultrasounds that we normally do. Let's go up there. With the same protocol of ultrasounds that we normally do. And I think that this will be the same situation. If we have any residual or anything like that, then we know that there is a restenotic issue.
Do you do ABIs on these kind of patients, PK?
We do definitely. We'll get an ABI TBI.
You think ABI is recommended in a patient with stenting?
I think that definitely, it depends on what you're looking at. If you want to get a baseline ABI to see what things are doing, then I think it's worthwhile to get a baseline ABI. If you have a drop in your ABI, then you know there are issues going on. I definitely think ultrasound is the way to go, but I think if you don't have one, at least you have some marker of what's happening for you in your patient.
Right.
I think if you're looking for, but remember, I think treating a stent restenosis without a clinical syndrome is not really indicated. So
Right.
there's no reason to worry about that. If their clinical syndrome is solved and you have DESs, you can assume that the DESs may be occluded if the ABIs drop, but if they don't have any issues, then that's fine.
You fell short a little bit.
Yeah, it
but
had to.
I think it's okay. You can do
I think
DCB
I'm going to
and
leave
PK.
that for now.
Yeah.
That's absolutely fine.
And then I'm
I
going to
think
take a
that's
foot
okay.
shot here.
I think 4.0 can accommodate there, right, PK?
Well, let's see what after he revascularizes the pop. But now we'll see with the injection here. Not much better, but definitely better filling of the
But
foot.
I think you can access this.
Oh, we can
feelers.
definitely access
We can
this, but you can
definitely
see it's
access
much
this from
better
fetal
filling of the foot
ultrasound,
for
yes.
us.
Yeah.
So I think at this stage what we're going to do is we're going to stop. I'm going to make sure we don't have any bleeding issues
right, yeah.
here in the anterior tibial. I just want to make sure that we go more lateral.
Now, Sandeep was talking about, I think that lateral plantar artery is from the peroneal is forming the arch.
Ready?
Yeah.
Inject. So we'll make sure that there's no extravasation here. As you can see here,
Nothing. That artery is, that plane is shut down.
it looks like it's fine.
Yeah.
Yeah.
So I think at this stage we're going to stop here. We're going to go ahead and Sandeep is going to fix that SFA proximally and either with an atherectomy DCB. And then once we completely revascularize the entire leg, we're going to see how she does, get ultrasounds as follow-up, and then we'll see you back next month, either at Link Mount Sinai or at the Fellows course or at our live case next month. So again, on behalf of Vishal and the entire team here, thanks again, guys. We'll see you next month. Thanks,
Thank
Karthik.
you.
Great job.
Thanks.
Great job, PK. Great job, Vishal. All right, guys. So I think it's a great demonstration of what PK has shown today. I think we showed a vessel which was totally closed. We are trying to revascularize and what happens with unsuccessful revascularization. And if you suspect any perforation or dissection, how to deal with it. I think PK has demonstrated fantastically. Now not to be too aggressive and rush into doing things, and you can be safe, hold on to your horses and just manage it. And then I guess we showed infrapopliteal stenting techniques. So again, I thank you on behalf of PK and Vishal and all the team here, endovascular team here at Mount Sinai, and we look forward to seeing you at Link Mount Sinai or the live case next month. Thank you.